Hello everyone, I shall discuss with you PH 3.7, that is competency in pharmacology, and that states prepare a list of essential medicines for a healthcare facility. Now, use of essential medicine provides easy access to healthcare, and this competency will be divided into two parts. Part 1 will be the knowledge component of the competency, and part 2 will be how to prepare the list based on these fundamental points. The competency component is skill, level is knows, shows how, it is a core competency, and I'll prefer a lecture and demonstration at a skill station how a list is to be prepared. Assessment is done by YOC and logbook entries. The same can be integrated with general medicine competency where drug selection is required. Furthermore, the same competency can be utilized for postgraduate training, in that a postgraduate in pharmacology may prepare essential medicine list for a secondary healthcare facility, whereas an undergraduate MBBS student may prepare essential medicine list for primary health center. The component of part 1 discussion is understanding essential medicines and essential medicine list. Then what is a WHO model list of essential medicines? What is national essential medicine list in India? And what are the advantages of use of essential medicine and essential medicine? Now, essential medicines are those that satisfy the priority healthcare needs of population. WHO defines essential medicines as those drugs that satisfy the health care needs of majority of the population. They should therefore be available at all the times in adequate amounts and in appropriate dosage forms at a price a community can afford. Therefore, the essential features are the priority health care, one, second is availability, third is in adequate dosage forms and number, and then final is the cost effectiveness. We will discuss these points. There are advantages of using essential medicines and essential medicine list because careful selection of limited number of medicine enhances quality of care and rational use of medicine. This is very important to consider. Then it also allows better management of medicines. Management means procurement, distribution, supply, everything, and monitoring. Everything is required. And more cost-effective use of health and financial resources in developing countries. It enhances access to health care because medicines and healthcare needs are met with. It increases public confidence in health services provided by the NGOs, government, semi-government organizations, because medicines are available uninterrupted supply. It provides framework for basic and in-service training of nurses and doctors, that is healthcare providers. Also, it helps in health insurance benefits and public health education based on essential medicine and essential medicine. The first point was it promotes rational use of medicine because medicines are selected based on their efficacy, safety, suitability and their affordable cost. And it follows rule of rights, that is a right drug for the right patient and right. WHO model list of essential medicine was introduced in 1977, and before that Tanzania was the first country to introduce essential medicine list around same time. This list by WHO is revised every 2 years by the expert committee, and the current version is of 2023. The list has core essential medicine list and supplementary medicine list. The supplementary medicine list is for special use. There is also a separate essential medicine list by WHO for children, and it is also revised regularly. Many countries draw country-specific essential medicine list from WHO model list. Now, at international level, a model list has many advantages. For example, major international health agencies like UNICEF base their catalogs on the basis of WHO model list. The same model list also guides for procurement and supply of medicines in the public sector. It also guides schemes for reimbursement of medical costs because essential medicines should be reimbursed. Medicine donations and production of medicines locally. The medicines which are required for priority needs should be manufactured locally. Essential medicine list also acts as an information educational tool for healthcare professionals. Now, National Essential Medicine List in India, the Ministry of Health and Family Welfare released the first list in 1996, which contained 279 medicines. The list was subsequently revised periodically in 2003, 2011, 2015, and the latest version is of 2022. The medicine included are based on their efficacy, safety, stability in ambient conditions, cost effectiveness and affordability. The list includes 384 medicines which are described in 30 therapeutic sections. It also recommends suitable level of the use of medicine. For example, for primary list is there, for secondary list is there, for tertiary list is there. Approximately 257 medicines are for primary, 60 are for tertiary care level, and the remaining are for both primary and tertiary care level. By primary, I mean they can also be used for secondary and tertiary level. Only generic, international, non-proprietary names are used in this. This is the facsimile of WHO model list and the national list of essential medicines. Now, the basic target, as discussed earlier, is at what level of use the essential medicines are for. For example, among the all available medicines, many of them are approved medicines, and countries, depending on their priority health need, will select their own essential medicine list, will be called as national list of essential medicines, and this can be used at various levels as primary, secondary and tertiary care level. In fact, we will be preparing a list of essential medicines for community health care facility, that is primary health center. All the medicines which are selected as essential medicines have characteristics that they are quality medicines, they are safe, they are efficacious, and they are cost effective, and they cater to priority healthcare needs. And the criteria of selection will be evidence for efficacy and safety. This evidence comes from multicentric trials, the Cochrane analysis, and from standard books. Relative cost effectiveness, that is cost of the unit of the drug, that is capsule or tablet, but more important is total cost of the treatment. For example, some medicine may be required 3 weeks, some may be required lifelong, some may be required for 5 to 7 days. That total cost will be determining the cost effectiveness. Now, all medicine should meet the standard quality, bioavailability, bioequivalence and shelf life criteria, and often pharmacokinetic considerations are used for some drugs where it is very important to show that free drug level or drug interactions or drug excretion are the determining factor for selection. Local availability in a suitable dosage form is also an important criteria, and as far as possible, single ingredient drugs are used. Fixed dose combinations should be avoided which are not actually approved or which are not rational. But there are certain fixed dose combinations for communicable diseases such as tuberculosis, HIV and malaria, and they are approved fixed dose combinations. They can be used. Pharmacologically sound rational fixed dose combinations are also available. For example, cotrimoxazole and the clavulanic acid amoxicillin combination. Such can be used as if they are otherwise effective and safe and cost effective also. Now, if there is a medicine which is useful in more than one disease and meets with the criteria, then it should be included because it will cater to more. Similarly, if there are more than one medicine for same disease, then a medicine which has maximum beneficial effect with minimum adverse effects should be chosen. And if two or more medicines have equal efficacy or safety, then criteria would be the one which is more time tested, where physicians are confident for its use. It is more cost effective, more suitable. Suitability becomes a major criteria in such situation, and easily availability because it enhances access to medicine. One must avoid unnecessary duplication of medicines, and preferably the list making essential medicine list should be linked with standard treatment guidelines, because standard treatment guidelines provide an evidence in the favor of use of drug. That's I'll give two or three examples how a drug can be selected. For example, if you want to select an angiotensin receptor blocker for hypertension and heart disease in essential medicine, and two drugs are available. Of course, there are many other drugs, but simple comparison would tell us that losartan is to be given twice daily, 50 mg. Telmisartan is given 40 mg once daily, as both have equal efficacy and safety in long-term use. Here, suitability and cost become important, because cost of treatment per month will be 54 for losartan and will be 28.8 rupees for telmisartan. So, suitable and cost-effective drug is telmisartan, and it should be preferred to be included as essential medicine in essential medicine. Another example is selection of antisecretory medicine for treatment of reflux esophagitis in the essential medicine list. Now, many antisecretory drugs, S2 receptor blockers, the proton pump inhibitors are available. I have cited just three drugs: omeprazole, ranitidine, esomeprazole, which is an improved version of omeprazole. Now, omeprazole is time tested, is found to be more effective in reflux esophagitis than ranitidine. Therefore, ranitidine is less effective compared to omeprazole. Esomeprazole is equally effective as omeprazole, but more effective than ranitidine. So far as safety is concerned, almost all three drugs have remarkable safety, except a few adverse effects from very long-term use on the vitamin B12 malabsorption or some local adverse effects. Most of the drugs are also suitable. For example, 20 mg once daily omeprazole or 20 to 40 mg once daily is omeprazole, whereas ranitidine can be given 150 mg BD for GERD, whereas it is given 300 mg OD for peptic ulcer. The advantage with ranitidine is that it is available as injectable form. The cost of medicine is not a major consideration so far as omeprazole ranitidine is concerned. So therefore, in comparisons, omeprazole should be chosen because it is more cost effective and is suitable with safe and effective consideration. Whereas esomeprazole is also safe and effective, but it is more costly. The only advantage with ranitidine is it's available as injectable. Therefore, ranitidine should be chosen as essential medicine for emergency use, whereas omeprazole should be chosen for regular use in GERD, and it should be chosen as essential. Now, there are very little to choose among the available drugs. For example, in NCRs, ibuprofen, diclofenac, aceclofenac. There are many more, but these are comparable. So, ibuprofen in adequate dose is analgesic and anti-inflammatory, but smaller doses are only analgesic, whereas diclofenac is anti-inflammatory and analgesic in usual doses. Aceclofenac is like diclofenac. Now, these drugs have GIT adverse effects, but ibuprofen is reported to have less GIT effects than other anti-inflammatory analgesics. Diclofenac also has somewhat less GIT, but it has more cardiovascular risk because it is found to be relatively more COX-2 selective. So, liver damage, cardiovascular risk should be considered before selecting diclofenac, and aceclofenac is better tolerated than diclofenac but also carries cardiovascular risk. Therefore, when we see the suitability, ibuprofen has to be given 3 times daily, diclofenac 3 to 4 times daily, but not for children, and aceclofenac can be given twice daily. It is more suitable compared to others. The cost of the treatment is not much different. Therefore, here cost effectiveness is not to be seen, whereas we have to see the suitability, safety of the drug, and it appears that for regular analgesic and anti-inflammatory use, ibuprofen is a better drug compared to other drugs, but when injections are required, then injection diclofenac can be used. There is very little to choose among diclofenac and aceclofenac, but diclofenac is chosen because injectable is available. So diclofenac can be used as injection, ibuprofen for regular. I have tried to explain how a drug selection can be done. So in summary, essential medicine list includes cost-effective medicines for priority conditions. The selection of suitable medicines is based on evidence of their efficacy, safety, and preferably should be linked to evidence-based clinical guidelines to provide efficient health care to the public. There are several advantages. The wider availability of medicines to most of the population increases access, improves health, and increases confidence, and it also helps in improvement in drug dispensing and patient compliance, and it helps planners and policy makers to allocate their limited funds and resources for bulk procurement and distribution that becomes more cheaper and cost effective. So this finishes with the part 1. In the part 2 of this competency, I shall discuss how an essential medicine list to be prepared for primary health center.